Hello, I'm Ioana Preston, the Director of Pulmonary Hypertension Center at Tufts Medical Center. And I'm joined today by Drs. Valerie McLaughlin and Vic Tapson, my colleagues and friends. Hello. Hi. Today we will be talking about goals of PH treatment in low-risk patients. Vic, how do you assess your patients with pulmonary hypertension in your clinical practice?
Well, nowadays, I think it's really important to aim for this low-risk criteria, low-risk status. And we've got several ways we can do this. We've got the REVEAL score. It's been around a long time and been modified. And we have several registries. They're European registries, have been very helpful in identifying what low risk means and actually giving us follow-up. The Swedish registry, the French registry, the COMPARE registry, all of these have come up with some low-risk criteria. They're very simple, and most of them include things like functional class, 6-minute walk, BNP, and also some invasive criteria. So these are the registries that have helped us identify what low risk means, and now we're trying to shoot for that in our patients.
And Val, how do you apply them in your everyday clinic? And when do you use invasive versus non-invasive measures?
Yeah, Ioana, this is a great point. I mean, one of the objectives is getting a patient to a low-risk status and keeping them in the low-risk status. When we see patients in clinic, we do a structured follow-up. Of course, you talk to the patient, and that helps you assess their functional class, which is an important prognostic indicator. We do a hall walk with every visit, and we do labs with every visit, including the BNP. One of the papers from the French registry I found very impactful was the essentially non-invasive approach. In fact, when you added BNP to the predictors, the hemodynamics fell out, such that you could have 3 variables that defined a low-risk status: functional class 1 or 2, hall walk greater than 440, and BNP less than 50. It's so easy to do in everyday practice, and we do that. Not to say that we don't occasionally do hemodynamics if a patient's not responding the way we like, or if data is conflicting, or we need the data to really show the patient that they need additional therapy. We do hemodynamics, we do echoes regularly as well. But I think the non-invasive French approach is very easy to do in clinical practice.
If they're all very good.
Yeah.
If all the numbers are very
right,
good.
If all the numbers are good, then they're low risk. But if not, then you need to move on and do something else, sure.
And the patient perspective, how do you put it in the equation, Vic?
So I think, well, there's a couple of ways we can do this, and I really like the idea of the French criteria. If you have 3 out of 4 criteria, you're low risk, and you can do this just non-invasively. So from a patient's perspective, to me, it's very simple. At every clinic visit, we look at functional class, we look at a 6-minute walk, and we look at BNP. And so we have those risk criteria at every visit. We don't tend to repeat right heart catheterizations in our patients unless there's a diagnostic or some sort of dilemma. So we like the idea of a non-invasive approach here. So that's kind of, we let our patients know these are very simple parameters we can follow. I still do believe that part of our low risk criteria are just talking to the patient. How are you doing? How are you doing compared to last time? Getting a good, simple history.
So listen to the patient.
Right.
Listen to the patient.
And the patient perspective, we always have to remember, it's not always exactly what we think, right? You know, like, we're fixated on a hall walk number or whatever. They want to be able to play with their kids or take care of the house. Like, that's an important part of their treatment goal as well, getting them to do what they want to be able to do.
Great point.
Thank you very much, both. Today we discussed about goals of care in patients with low-risk pulmonary hypertension. Thank you.